let's get started on the critical care case. Thank you to Doctors Beta, D'Souza, Kim, and Chan for all their help with the presentation. So we'll start with a patient who is at home. Their granddaughter called EMS to pick up the patient. They said that since 2 o'clock, the patient had been developing shortness of breath, was unable to breathe, is on 2 liters of oxygen and found on 2 liters of oxygen in the bed. The vitals are shown here, tachycardic. There was no SpO2 recorded, but they did place the patient on 4 liters of oxygen by nasal cannula and brought to the hospital. On the initial assessment in CCT, the airway was intact, clear speech, the breathing, tachypnic and bilateral rails. Circulation was okay, and patient was ANO times 3. The heart rate was still elevated at 110. Patient was pretty significantly tachypnic at 37 per minute, and the SpO2 was 82% on 2 liters of oxygen, which was the patient's baseline O2 requirements, afebrile, and glucose 140. So based on those vitals and kind of what's been going on, could you please call out some problems to add to our preliminary problem list? Yep. Tachypnea and tachycardia, right. And they did report a cough. So the initial assessments, interventions, so cardiac monitor was placed, peripheral access, oxygen 4 liters was kept on the patient, 500 liters, 500 milliliters of fluid was given, Duanebs times 3, as well as Tylenol for the elevated temperature, but not febrile. EKG was performed and a point of care ultrasound as well. So you get more history and you find that the patient has diabetes, hypertension, pulmonary fibrosis, and asthma, and they had a cough since yesterday, shortness of breath. There was a cough, rhinorrhea since yesterday, started to feel dyspneic, struggling to catch her breath, with chest pain most pronounced when coughing. Medications, albuterol is prescribed to the patient, amlodipine, Advair, mirtazapine, montelukast, prednisone, and the allergies are penicillin, which is a rash. Patient has never smoked tobacco or used tobacco, is not really a drinker, and no other drug use. So on the exam, the patient is in respiratory distress, but non-toxic appearing. Normal HEENT. Patient was tachypnic with abdominal retractions with rails on exam. No wheezing or rhonchi. Tachycardia was palpated, but normal 2+ pulses, normal heart sound, no murmur. Abdomen was okay, no pertinent GU exam. And the extremities were warm, dry, without any edema. ANO times 3. Here was the EKG that was collected. If anyone can just give a quick read, maybe a junior in the room. How about you, Ryan? Yeah, so what do you think of that V2, V3 picture? Is there something that you could kind of tell just based on what you said? But yeah, so you could maybe say the patient would have LVH based on this EKG, and it's sinus tachycardia without any T wave inversions or ST changes. Good. And then on ultrasound, you see diffuse B lines of both the right and left lung interstitium. There is lung sliding, and there's a hyperdynamic kind of global ventricular function that you evaluate, and no pericardial effusion. So now if we could kind of develop a differential diagnosis, so we can call out any diagnoses on the list. What was that? Yep, pneumonia, CHF, pulmonary fibrosis, NPE are pretty all on there, as well as pulmonary hypertension. Lower likelihood, CHF, just not really fitting the picture here, despite there being B lines. No pneumothorax, really, because of the lung sliding. And even though there's chest pain, you're not really seeing a picture of ACS here. So on reassessment, patient still tachycardic, normotensive, still tachypnic on the nasal cannula, though the SpO2 is okay. But because of the worsening tachypnea, the patient is advanced to high flow nasal cannula, 40 liters, FiO2 40%. Any other further testing and diagnostics or consults that we want to do at this time? Yeah, trope BNP, VBG, and a chest x-ray. And then at that time, because this patient just seemed to be deteriorating, they also got a critical care consult at that time. So the results, we see a venous gas with the results here. Another junior can help me to kind of interpret this VBG. How about Joy? Yep. Right. So respiratory acidosis, but to go one step further, you can call it either an acute or a chronic respiratory acidosis. And this is something that I keep in my notes, thanks to Dr. Singer. And it's essentially if you go up 10 PCO2 from 40, you expect the pH to go down by 0.08 acutely or by 0.03 chronically. So if we go back to this, Joy, would this be a chronic or an acute respiratory acidosis? Yeah, so if you go, so we're going up 20 PCO2, right? And the pH has gone down by 0.06. So actually, it would be chronic because we're going down 0.06, which is 0.03 times 2, because we've gone up 20 or 10 times 2. If that makes sense. So some 7.40 down 0.06, but we've gone up 20 in the PCO2. So this is kind of be more of a chronic picture that we have, which makes sense. Patient has a chronic disease, slowly getting worse, and then the past day really became symptomatic, requiring to go to the hospital. So we have a chronic picture here, which gives you the understanding that it took the patient a while to get there. So you'll have a little bit more time to give interventions to try to reverse the process instead of there being, and you were going to expect a slower amount or a larger amount of time for the person to get better with interventions, as opposed to say a flash pulmonary edema. It's not a lot of times it's acute. You give acute interventions, they get acutely better. But the chronic case took a while to get there. You give interventions, you expect it to take a little bit longer to reverse. Blood testing here, nothing too big. The VBG was giving us a lot more information, but you can see the chloride's a bit down. White count is high at 14.6, but everything else is pretty okay. Here's the chest radiograph. You see here a pretty typical picture of interstitial lung disease. And the radiologist says unable to exclude pneumonia given the diffuse reticular and interstitial densities. So here you see diffuse reticular interstitial densities, maybe a small bilateral pleural effusion, rightward deviation of the trachea, which could be a tortuous vasculature or a mediastinal lesion, and then diffuse gaseous detention of the large bowel. So the updated problem list at this point is we have acute respiratory insufficiency. And at that point, we also, to add to that, pneumonia, we have a white count, we have some evidence of it, patient's high risk. So levofloxacin is given, as well as 1 gram of salumedrol. And the patient's now even more tachycardic. Respiratory rate has come down just a bit, but still tachypnic. And the SpO2 is still okay. But at this point, because of the continued tachypnea, patient's still not looking super great. High flow is transitioned to BiPAP. BiPAP is attempted for 1 hour. Respiratory rate is worsening with tidal volumes that are good at 400 to 500. SpO2 is low normal. Patient's anxious, still abdominal retractions. And because of this, patient is intubated at that time. So 2 to 3 hours of nasal cannula, 2 hours of high flow, 1 hour of BiPAP, intubation is then done. Critical care is verbally recommending intubation, and it's done with etomidate, rocuronium, and the patient's placed on VC-AC with the above parameters and propofol for sedation. Patients admitted to MICU, chest x-ray confirms ET2 placement, and critical care recommends a CTPA just to rule out PE at that time. Antibiotics which were given, keep the O2, avoid hyperoxemia, but also keep O2 up, and then consider low tidal volume ventilation to avoid volume trauma, and the vent settings are changed to the ones up there. They also are recommending a plateau pressure less than 30 to 32. So just wanted to pause there to kind of talk about plateau pressure in mechanical ventilation. So the plateau pressure is the amount of pressure needed to keep the lungs inflated in the absence of airflow. It can be measured during invasive mechanical ventilation by applying an inspiratory hold on a well-sedated patient at N inspiration for about a half a second to 2 seconds. That pause or inspiratory pause is applied after a breath has been delivered, but before exhalation. Increased plateau pressure can result from conditions that cause lung stiffness, decreased lung compliance, and indicates the elasticity of the lung in the chest wall. So this would be like pulmonary fibrosis, ARDS. And if you want to limit that plateau pressure in order to reduce the risk of ventilator-induced lung injury, and the peak inspiratory pressure is the highest pressure that occurs in the lungs during the inspiratory phase of breathing. And that represents the amount of pressure needed to overcome airway resistance and chest wall compliance in order to deliver the breath. So if you see here, the airway resistance is kind of between the pressure, the plateau, and the peak, and the compliance is between kind of that peak and plateau. And the other more academic way of calculating it would be with this calculation, but we don't have the static compliance. So you wouldn't really make this calculation in the ER, but just for academic purposes showing there. So based on everything, what is our diagnosis here? Yeah. So we have an acute exacerbation of interstitial lung disease as well as treating pneumonia. So, what we'll do is kind of go over the pathology and epidemiology of interstitial lung disease, the management of it, and then non-invasive mechanical options, challenges and solutions, as well as the morbidity and mortality associated with intubation in this population. So, interstitial lung disease are characterized by infiltration of the alveoli with inflammatory cells, fibrotic changes that occur predominantly in the interstitium, leading to a restrictive lung physiology. And then there's a variety of different etiologies. So there can be pulmonary changes ranging from granulomatous inflammation without fibrosis to severe diffuse parenchymal fibrosis with distortion of normal pulmonary architecture. And I honestly forgot or didn't realize that there's over 200 different non-malignant pulmonary diseases kind of in this category. Some are known and some are idiopathic. And so if you kind of look at this chart here, you have lots of different categories. There's a lot of different reasons for why someone would have this disorder. And so you have connective tissue diseases like dermatomyositis, polymyositis, RA, scleroderma, and Sjogren's. You have exposures to occupational hazards, medications, and recreational use of drugs. Idiopathic, which is its own pretty large umbrella, sarcoid, and then you also have eosinophilic pneumonia, Langerhans, neurofibromatosis, and vasculitides. And then within the idiopathic interstitial pneumonia, you have kind of unclassified, which is a large percentage. You have a lot of different rare ones, and then you have kind of the majority of them, which would be like bronchiolitic interstitial lung disease, idiopathic pulmonary fibrosis, or IPF. It's kind of the biggest one, cryptogenic organizing pneumonia, and then an acute interstitial pneumonia. So they can be assessed by a variety of factors, and the most common ones are the symptoms, number one, chest CT findings, number two, and then your pulmonary function test, number three. And based on each of those three, you can then classify them into the different types of interstitial lung disease. So here's the epidemiology. Not super rare, but also not super common. Something to keep in mind, though, like you've probably seen it in the ER, or if you didn't realize it and you just saw B lines, maybe you thought it was CHF, but you admitted the patient, and then after a while that they realized it really wasn't CHF. And between 10 and 30% of patients with ILD will have an acute exacerbation in the first 2 years of diagnosis. So the way to actually call it an acute exacerbation, all four of these components need to be met. So number one, they have to have a known diagnosis. Number two, worsening dyspnea in the last 30 days. Number three, CT findings with new ground glass opacity, so you have to have a baseline. And number four, deterioration that's not fully explained by fluid overload or CHF. If you don't have a CT baseline or new CT findings, then the term suspected acute exacerbation could be used. Here are all the different triggers that's associated with an acute exacerbation. They typically involve infection, medications, microaspiration, or worsening air quality. And infections may cause between 10 and 30% of exacerbations. However, 52% of exacerbations don't have a known cause. An exacerbation is most common when the patient has a low FVC and a low DLCO, or diffusing capacity for carbon monoxide, a low 6-minute walk distance test, concomitant pulmonary hypertension, a poor baseline oxygenation, or a recent decline in FVC. So due to the underlying restrictive pathology, people with ILD typically experience gradually worsening dyspnea with exertion, as we kind of talked about just before, just because of that diffusion capacity is low. And so people get more dyspneic as you exert yourself. And a non-productive cough, because there's not a lot of fluid in the lungs. Hemoptysis and chest pain and wheezing may also occur, but it's not as common. And an acute exacerbation may be the initial presentation. Up to 30% of cases of people, it's kind of their first presentation to the ER. They'll typically have hypoxia, which will improve with oxygen, and may present with severe respiratory distress. It's considered a diagnosis of exclusion. So one should evaluate all other causes before kind of making the final diagnosis of acute exacerbation. So chest X-ray, we kind of already went over. And then on POCUS, you're going to see those B lines and a thickened pleural. So ultrasound is useful for evaluating undifferentiated dyspnea, as we know, but it can be challenging because you'll see those B lines, which can mimic multifocal pneumonia, COVID, congestive heart failure. But in this case, it's diffuse, as well as what they call non-homogeneous. So it's not going to be like at the bases and maybe a little less at the apices. It's kind of going to be scattered and not so diffusely homogeneous. You'll also see pleural line abnormalities, so an irregular fragmented pleural line and subpleural abnormalities. So ultrasound is superior to chest X-ray for ruling in significant interstitial syndrome, and a negative ultrasound is superior to chest X-ray to ruling out significant interstitial syndrome. Chest X-rays here, as we talked about, radiograph is 80% sensitive and 82% specific in diagnosing ILD. And then the pulmonary function testing and like rheumatologic testing, CRP, all that can be done inpatient or outpatient, but you're not really going to be doing that in the ED. High resolution CT is preferred. So this is a specific CT that you do in this situation, which you'll do in stable patients. And it will demonstrate the several types of opacity. So linear, reticular, nodular, and reticular nodular, as well as adenopathy and honeycombing. And the high resolution has a greater ability for detecting other pulmonary complications like pneumothorax, pulmonary hypertension, which is going to be so much harder to identify on this kind of radiograph. One caveat, which is something that I learned, is that The ground glass opacities changes artificially when you do a CTPE study. So what you would want to do is call the radiologist and tell them to combine a CTPE with a high resolution CT, so they can adjust for this artifact and allow evaluation of those ground glass opacities. So you don't just want a normal CT, you want a high resolution one with the CTPE. And you probably will do both because you want to rule out the PE in order to fully diagnose the acute exacerbation. So here we'll move on to the management. We'll talk about treatment of respiratory insufficiency, as well as the other primary modes of management in the ER. So high-dose steroids, sometimes administered as pulse therapy, are common, though the data is actually pretty limited because there's no randomized control studies comparing steroids with placebo. So there's a weak recommendation for steroids, and you can do either the prednisone 1 mg per kg per day, or the 1 gram as we gave in our case for 3 days, and you can taper. So it's typical treatment, but the evidence is not super there. It's a weak recommendation. So for antibiotics, they're recommended to be given to all patients with acute exacerbation, because bacterial infections do account for about 10 to 30% of triggers. However, the antibiotics of choice are actually third generation cephalosporin, like a ceftriaxone, with azithro, and Bactrim to cover for PCP. So it sounds like in an open label prospective study, patients treated with high-dose steroids and azithro for 5 days had 20% mortality at 60 days compared to 70% in a group of high steroids with fluoroquinolones. So it seems like the move is to do the azithromycin with ceftriaxone, and then Bactrim is another thing that's been kind of discussed and advised just because of that high rate of steroids, immunocompromised state, and colonization with PGY4 Immunosuppressives are starting to become more popular in this population. Despite lack of controlled comparative studies, the current guidelines recommend treatment with immunosuppressants, as small observational studies have shown a trend toward prolonged survival compared with steroids alone. However, you shouldn't be really starting these in the ED, and even if the patient is on it, you can kind of talk to critical care to get them on board. The most common ones are these azathioprine and the mycophenolate, although the other ones are also seen. So the bulk of the rest of this lecture is really going to be on managing hypoxemia. This is kind of the thing that's going to maybe save the patient versus the patient kind of leading down a path where they will end up dying. And so with patients with ILD, particularly in those with long-standing or chronic ILD, having a large diffusion gradient, which limits gas exchange, is going to create a VQ mismatch leading to hypoxia. So it's reasonable to start with conventional oxygen therapy, including nasal cannula, oxymask, though frequently management of significant hypoxia will require more concentrated interventions. So one study found that both high flow and non-invasive ventilation reduce short-term mortality when compared to just nasal cannula, with no difference between the two. However, it does seem like our ED population, high flow is better tolerated, so would be a better first line to attempt. Patients who improve with non-invasive demonstrated reduced mortality and the need for endotracheal intubation, but those who fail non-invasive have higher mortality regardless of intubation. So high flow does have its advantages, as we've talked about today. Typically goes up to 60% liter or 60 liters, 100% FiO2, provides anatomic reservoir of oxygen in the pharynx, reduces airway dead space, provides that low PEEP of around 2 to 3, and improves work of breathing, and also has that humidification area that will just help the patient as opposed to the nasal cannula. So this is what it looks like. You've all probably seen it. You can change the FiO2 just by clicking the numbers, and then the flow meter up to about 60 liters. Although well tolerated, patients with worsening dyspnea worsening oxygenation, or continued tachypnea, like in our patient, it would be advisable to then move to BiPAP. So the non-invasive ventilation in this mode, breaths are triggered by the patient unless apneic, in which the backup rate is responsible for initiation of the breaths. You have the IPAP, or the inspiratory positive airway pressure, and then your EPAP, your expiratory positive airway pressure. And inspiration is an active process that requires more energy than expiration, which is the passive process. So IPAP is always greater than EPAP. The indications for it would be COPD exacerbation, CHF, other causes of respiratory failure like ILD, a DNI status, and after extubation or transition onto the BiPAP. The contraindications would be extreme agitation despite treatments with medications, the inability to protect their airway, coughing, drooling, or trigger a breath, skull fractures, recent GI hemorrhage, or other risk of emesis or copious secretions, or an untreated pneumothorax. These are the three most common options. We typically see the facial mask. The nasal mask is an option. Theoretically, it's supposed to help with or eliminate the risk of aspiration, but you have an air leak more often in the mouth, and it's reducing your ability to really provide that ventilation. And then you have this very funny guy just sitting there with his helmet that is not really widely available in the US. So we'll see if it becomes more popular in our career, but right now we don't have these astronauts in our ER. So the different modes, you have your CPAP, which is when which is basically just applying EPAP, and it's really meant to provide oxygenation, open up the airways like you have in sleep apnea. This is typically what EMS will give for CHF. You have BiPAP, which is the difference. You have your IPAP and EPAP. It's triggered with a backup respiratory rate, and this is more to help with ventilation and oxygenation. The last one is the AVAPs, which I'll go into a little bit later, which is less common, but I think we all should be aware of it and definitely use it in the right situation. So say you have low SpO2 or PaO2 on an ABG. The two parameters to change in BiPAP is to increase FiO2 and your EPAP, which is equivalent to PEEP in mechanical ventilation. So with increased EPAP, the patient exhales against a threshold resistor, generating preset positive expiratory pressures. So the purpose of this is to increase the transpulmonary pressure gradient and improve pulmonary expansion. So that's kind of how I always think about it, is that as you're increasing those alveoli, you're increasing the pressure gradient, more oxygen is able to get through, and then improves your oxygenation. Say you have a ventilation issue or high PCO2 or a low pH, what you want to do is change your driving pressure and your respiratory rate. So increasing your respiratory rate will ensure patients taking enough breaths to actually ventilate PCO2 out of the system. And the same is true if you increase driving pressure. So driving pressure is not to be confused between non-invasive and mechanical ventilation. So driving pressure in your non-invasive is your IPAP minus your EPAP, as opposed to when we talked about it in mechanical ventilation. So this drive is going to increase your tidal volumes in order to blow off more PCO2. So typically we think respiratory rate and tidal volume, but the way I'm presenting it is more thinking about the driving pressure. Because if you change your driving pressure, the distance between your IPAP and EPAP, that's going to translate into a higher tidal volume. And you want to titrate your goal to the ideal body weight, which is 6 to 8 cc per kg based on their ideal body weight. And so this graph is something that I find really helpful. I'll have a good idea of just what the typical 6 ml per kg for your typical heights in the ER, and just kind of be able to easily, it's usually around 400. But I think in critical patients, you really want to know that specific range. And I'll definitely reference this for patients who, are on the extreme ends of the bell curve for height to ensure proper tidal volumes are achieved. And then here are the different parameters that you can change on non-invasive. So your FiO2, you can either start low, titrate high to the minimum FiO2 required to keep your desired SpO2, or start high at 100 and come down. Respiratory rate is that backup rate that we talked about. IPAP is usually between 10 and 20. EPAP usually between 5 and 10. I time is basically if you want to increase your I to E ratio, you'll have to turn down your I time. And then there's the rise time as well, which is usually like around 1 being the fastest, 5 being the slowest. So some things to keep in mind though in BiPAP is that you really have to frequently reassess the patient. So this is kind of the biggest thing. You can't just like throw it on, do your 10/5, leave, and just expect things to get better. You really, the number one thing that I would recommend is ensuring tidal volumes. So another pitfall would be the fact that like, why is the patient not having proper tidal volumes? So air leaks are really common. So the mask is not fitting well. You put it on right away, you walk away, you come back and you can hear it. You're at your desk, at your computer, and you hear it. Instead of just listening to it, you have to get up and actually tighten it. Maybe you need a different size of the face mask. And if all of those, and there is a tight seal and the patient is, there's no air leak, then you have to think about why there's not a good tidal volume. So is the driving pressure not big enough for the patient? Is the patient really anxious and agitated and they're just breathing too rapidly and not taking enough tidal volume? So these are all things that you have to reevaluate, especially on critical patients in the ER. You can also follow the blood gas results. But what happens is people will follow those. I find this more in the inpatient side than in the ER, but following blood gas results rather than the overall clinical picture. So like someone will come down and say, I just saw the blood gas results, like intubate the patient immediately. And you're sitting there saying, well, they're getting better, they're starting to wake up. So you really have to take the whole clinical picture into mind. Forgetting potential hemodynamic consequences of non-invasive. So hypotension is particularly something you have to really think about if the EPAP is high, and if the patient has increased ventricular afterload, especially in RV failure. So these are all things that you have to know before even giving someone an intervention, because you have to know how to troubleshoot and not just rely on a respiratory type to do so. So here are other kind of challenges that you'll face with BiPAP, specifically in BiPAP with patients with ILD. They could be, some patients I've seen will like think they're having too much pressure in the system and they can't handle the BiPAP. So, and if you're trying to de-escalate and tell them the importance of BiPAP to save their life, that works for like 10% of people. What you want to do is try to, maybe their driving force is too high and they're just getting suffocated by those high driving forces. So decrease that driving force. Maybe they will handle it better if their tidal volumes are 300 instead of 400, because on 400, they're not even tolerating it at all and they want it off. But if they go down to 300, that's better than having no BiPAP at all and they're less agitated. But say that doesn't work or their mental status isn't so great. There's kind of other reasons other ways that you can help the patient. So say they have respiratory hunger. You can utilize opioids in order to help with that. There's tachypnea, a high respiratory rate, and there's asynchrony, and the patient is meditating well. You can assist with medication, which I'll go into. So the reason why I want to bring up all these challenges is because in this specific patient population, mechanical ventilation invasive ones have an in-hospital mortality rate of 85 to 90%. So you want to do everything that you can possibly do in your repertoire in order to avoid intubation. And the poor prognosis is likely due to ventilator-induced lung injury, VILI. And it's specifically associated with this population, especially with fibrotic types of ILD. And for patients requiring invasive mechanical ventilation, a lung protective strategy similar to ARDS is recommended, as the stiff fibrotic lung is susceptible to barotrauma. And ventilator patient dysynchrony can lead to VILI. And so you'll want adequate sedation and maybe even neuromuscular blockade. However, ventilation with ARDSnet have failed with ILD also because, as I showed you, there's so many different types. And so there is this there is also a thought to, should this patient be transferred to an ECMO and transplant center? Because if they're not going to be able to do well on mechanical ventilation and you've had to resort to that, you don't have backups, you're basically having a death sentence for the patient, unfortunately. But this can be a really hard decision, especially if they're intubated and so critical. Is it possible to even transfer this patient to another facility? So like I said, it has to be taken very seriously. And the main factors to consider when intubating is poor oxygenation despite non-invasive, worsening or lack of improvement in the work of breathing. So taking note of their general appearance, retractions, tripoding, inability to speak sentences, and the patient's own perception of their breathing, and their mentation. As long as the patient is maintaining normally, you know that their PCO2 isn't profoundly elevated. And if their mentation is deteriorating, this is an indication for intubation. And then finally, the blood gas. VBG is sufficient to evaluate the PCO2 on that initial to see where the PCO2s are. And an ABG is not really necessary if you have a good waveform on PCO2. The only additional thing it's going to be giving you is that oxygenation. But if you have someone with like the forehead one and the earrings on and like you're not getting a good waveform, get that ABG to ensure that the patient isn't maintaining poorly because of their lack of oxygenation. So, but I would ensure to get the VBG to see where the PCO2 is, but following a VBG is not as necessary, but can add, more information as needed. So say the patient's not tolerating BiPAP despite changing the parameters, ensuring that the face mask is on correctly. Prior to intubation, you may consider anxiolytic and analgesic agents to help with synchrony with the machine in order to optimize tidal volume. So these are your options. Number one, opioids. Though opioid infusions, they can help to may work with the respiratory rate, but their mental status are going to go down. So perhaps a better strategy is low dose IV pushes to help with air hunger. But what I would more recommend are the infusions of ketamine and Precedex. So ketamine preserves your protective air reflexes, lowers airway resistance, increases lung compliance, and is less likely to produce respiratory depression. It'll increase heart rate and blood pressure, and keep in mind emergence reactions, especially with those with psychiatric history. Precedex can be used as an anxiolytic, sedative, and also has analgesic effects. However, the most concerning side effects are bradycardia and hypotension, but there's no respiratory depression. So a low dose could be attempted in some of these patients. Benzos really doesn't have analgesia, increased delirium. I wouldn't recommend it. Propofol is hypotension and apnea, not really recommended, and definitely not antipsychotics. This is also another technique that you can use for agitated patients. So say someone's agitated and asynchronous with low oxygen saturations on BiPAP. You can't go directly to intubation, and you can't go to RSI. So what you can do is this delayed sequence intubation. So you can't pre-oxygenate, patient's agitated. So what you can do is consider this as like a procedural sedation. You can give ketamine, protects their airway reflexes. You're basically starting a procedural sedation to oxygenate the patient with non-rebreather or with CPAP in order to ensure the patient's well oxygenated and has the highest rate of first pass success. So this is something to keep in mind that you can do in the ER. And then finally, I wanted to kind of bring up AVAPS, or Average Volume Assured Pressure Support. It's kind of this long name, but it's relatively new, aka starting in 2009. So it's been 15 years since we started. It's kind of like when I talk about buprenorphine being around for 20 years, but we call it relatively new. This isn't new anymore. Rather than having one fixed IPAP setting, this mode sets a minimum and a maximum value of IPAP, and the tidal volume is preset, at least theoretically. So the ventilator adjusts the inspiratory pressure from breath to breath to ensure the preset tidal volume is delivered. So this increases ventilator synchrony as the inspiratory pressure changes with each breath, thus improving patient comfort. And a review has shown that AVAPS has positive effects on pH and gas variation and patient comfort. And actually, in my own experience, kind of side story, I had a patient come in, not maintaining very well, had a PCO2 in the 120s, pH was 7.1, not doing very well. We did BiPAP for 2 hours. Patient wasn't improving or worsening. And we changed the settings from BiPAP, even with like high driving force, to AVAPs. And we left the patient, we were at downstate, running around doing all kinds of other things. We come back to the patient and they're doing actually much better. And we do another VBG and the pH had gone up, the PCO2 had gone down about 20 after not moving on BiPAP. And you looked on the monitor and the tidal volumes went from 100 to like 350 on AVAPs. So, and in that time, the critical care attending had come down and said, intubate this patient. And I was like, no. And we did this and we, prevented the patient from being intubated, this 80-year-old patient. And, I looked later and they didn't even have to go to the ICU, never intubated and walked out of the hospital. So it's like something that we should all have in our repertoire. And I think it's absolutely something that we should be doing after we've checked the seal and checked to see if you can move the driving force. So for this patient, the patient was, the CTPE was done and there was no PE. There was diffuse bilateral lung parenchymal architectural distortion with reticulation, cicatricial bronchiectasis, thank you, radiology, and subpleural predominant distribution. And there was a 3 centimeter central pulmonary artery, so there was evidence of pulmonary arterial hypertension. The patient was continued on salumedrol. The 1 gram was the first day, then 500 QD for 2, then 60 Q12. Fentanyl and propofol were used for sedation. A pneumomediastinum was noted on chest X-ray around hospital day 3, which did not get get super bad or significant. The vent settings were kept on pressure control with the above settings. At hospital day 8, there was rising PCO2. The blood pressure was above systolic 200, worsening acidemia, tachypnea, oxygen requirements. A goals of care discussion was had with palliative, and on hospital day 11, the patient was made DNR, DNI, and terminally extubated, unfortunately. So, in summary, acute exacerbation of interstitial lung disease is a diagnosis of exclusion. There's a very high mortality with intubation. And so what we do in the ER is basically it predicts and has a prognosis, highest prognosis factor of what's going to happen to the patient based on what you can do with non-invasive interventions, as well as giving antibiotics, giving steroids, and getting critical care involved early to see if any immunosuppressants need to be given, and attempting all of your different ways of overcoming the challenges that come with non-invasive ventilation, and keeping in mind anxiolysis, keeping in mind delayed sequence intubation if that is necessary, and realizing that B-lines on a patient with a normal EF and no pitting edema, no history of CHF, something to keep in mind on your differential and not just admitting the patient for new onset CHF. Here are my references, and that's it.